Welcome back, class. It's Dr. Lindner. We are still on the heart, and we want to talk a little bit about the heart sounds and the valves, because this is kind of interesting, isn't it? When your doctor or nurses take a stethoscope and they put it around your heart at specific areas, they're listening for possible murmurs or abnormal openings or closings of these valves and what things should sound like and what is the lubbed up. What is that sound? So we're listening to the closure. We're always listening to the closure of valves. And the way I try and tell my students to remember this is just think about someone leaving a classroom and then the door slams shut, right? You can always hear a door closing. It leaves more of an impression than the door opening. So the closure of the valves is what we're hearing. Lubbed up, lubbed up, lubbed up, lubbed up, lubbed up. The lub is the AV valves closing. What are the AV valves? The AV valves are the atrioventricular valves. It's the bicuspid and the tricuspid. What's the other name for bicuspid? Mitral valve. Why are they called bicuspid, tricuspid? Because upon dissection, the bicuspid has two cusps to it, and the tricuspid has three cusps to it. The dup sound, lubbed up, the dup is the semilunars closing. What are the semilunar valves? It's the aortic semilunar and the pulmonary semilunar. So here's the lub, and here's the dup. Lubbed up, lubbed up, lubbed up, lubbed up. So the AV valves closing are the lub, and the dup sound are the semilunars. Now, how can we listen? Where do we listen for these heart sounds? Now, you would think that you would place the stethoscope where anatomically where the valves are located, but it's not the case. And this is why in AMP1 we stressed osteology. Now, right here is the manubrium of the sternum, and here is the body of the sternum. And then right here at the tip is the xiphoid process. There's a very important location right here, and it's called the sternal angle. It's called the sternal angle, or it's also called the angle of Louis, depending on what textbook you're looking at. It's either called the sternal angle or the angle of Louis. Now, how do you find that? It is a horizontal line, but it's a very important palpatory landmark. Palpatory or palpation means to touch. So if you palpate and feel on yourself right here's a clavicle, and here's a clavicle, and if you go right here to the jugular notch or the suprasternal notch, there's a depression right here on yourself. And if you drop down about 1, 2, 3 to 4 finger breaths, right? One finger horizontally is a finger breath, 2 fingers, 2 finger breaths, 3 fingers horizontally. So depending on the individual, it could be like 3 to 4 finger breaths. You're going to get to this horizontal, palpable, bony ridge going this way. Once you can feel that, and you go to the right of that or to the left of that, again, this is the right and this is the left, you're at the second rib. That is a major landmark. That sternal angle or angle of Louis, once you find it, whether you go to the right or to the left, you're at the second rib. And when you get deeper into your physical examination books, deeper into your medical education, you will learn exactly what I just taught you. But when you go below, 1 finger breath below the second rib is the second intercostal space. Then you have the third rib, the third intercostal space, the fourth rib, the fourth intercostal space, the fifth rib, the fifth intercostal space. Now, where are you going to place the stethoscope? You're going to place it over bone, or do you want to place it under a hollow region where you can hear the sounds? So of course you're going to place it in the intercostal spaces, but you have to know how to get there. You have to know how to count them. So here is the second intercostal space. On the right side, you can hear the aortic semilunar valve. The second intercostal space on the left side, you can hear the pulmonary semilunar valve. Then you go fourth rib, fourth intercostal space, fifth rib, fifth intercostal space. Now, once you're here just close to that fifth intercostal space, but somewhat center, this is where you can hear, where are we? Let me get this straight. Here is our bicuspid and tricuspid. So here's our tricuspid. If you follow that, here's the tricuspid valve, but you have to go to these right angles to it, right? Think of it as these are walls, and if you're clapping here, if someone's clapping their hands, you're going to hear the echo here. If you're clapping your hands here, you're going to hear it loudest at the echo here. If I'm clapping my hands here, it's going to echo greatest here. And if we close or clap our hands here, we're going to hear it loudest here. So think of it as the echoes, right? You're hearing the echo of it, not necessarily right over the anatomical location of where the valve is, but think of it as the clap is, you're going to hear it at the end of the room, right where the walls are. It's going to bounce off loudest there, okay? So keep that in mind. Here's the bicuspid valve. The bicuspid valve is at the fifth intercostal space on the left-hand side where the apex of the heart is. So that's auscultation, being able to hear those sounds. Now, let me see if I can erase this here just to show you something. So now that we're here, you can see the brachiocephalic, the left subclavian, the left common carotid artery, and then the left subclavian artery. You can see them off the top. Now, stenosis, prolapse, and regurgitation. We're still talking about these valves. A stenosis means an incomplete opening of a heart valve. Stenosis means narrowing, so it's very, very narrowed. A prolapse is when there's an inversion of a heart valve, but there's no significant backflow of blood. A regurgitation is a prolapse. It's an inversion of a heart valve, but here we have significant blood flow back into the atria. So here we see the full heart. We see the right atrium and left atrium. Here's the left ventricle. We can see the mitral valve. We can see the chordae tendineae. We can see the papillary muscles here. Now there's some sort of defect. There's a malfunctioning mitral valve, and in this particular case, it can allow the backflow of blood into the atrium. Here, on the left-hand side, here's the left ventricle, here's the left atrium, here's the mitral valve. It's good. Here, remember let me just make this black for a second. Remember, when this pushes blood, it's pushing upward. It's pushing blood and forcing it this way. So we really need good integrity of those chordae tendineae. If they become overstretched or weakened, look what happens. You start to get this prolapse where it starts to invert, not level off, not nice and strong. Now it's prolapsing. Now all the way on the left, we have a prolapse, but now it's so distorted that now we can get this leakage of blood that as the ventricles contract, pushing blood upwards, not only is it creating this prolapse, it's also separating this, and you get a little sneakage of blood back up into the atrium. No good. When we come back, we'll talk about the blood flow to the heart itself.